This will be an instructional course on injections into the shoulder, both techniques as well as therapeutic value. We use the concept of the shoulder joint being a three-story house with three levels: the glenohumeral joint, the subacromial space, and the acromioclavicular joint. The first level has the roof of the rotator cuff. The second level has the rotator cuff as the floor, and if one goes higher up, there is the AC joint. Level 1, the glenohumeral joint. This is the main joint itself of the shoulder, the ball and socket, and it is the space between the humeral head and the glenoid. Pathologies mostly occurring inside the joint is osteoarthritis, synovitis, frozen shoulder, biceps tendon problems, as well as pasta lesions. Pasta is partial articular side tendon avulsion. Arthritis of the ball and socket joint itself, and here is synovitis with a red synovium, frozen shoulder, very red and irritated, biceps tendon pathology with the biceps being inside the joint, and then partial articular supraspinatus tendon avulsions. The tests: firstly, painful abduction with external rotation. That's a very typical positive test. And as you can see here, the arm is placed in abduction and forced into external rotation, which usually would elicit pain in this condition. Limited passive motion is typical of intra-articular conditions, and all motions are usually passively restricted. Abduction passively would always be limited, as well as the other motions. Here you see passive external rotation, which would be much less if there was pathology. Then abduction external rotation would be limited in these conditions, as well as abduction with internal rotation, often severely limited. Special mention has to be made of passive external rotation, which is very limited in frozen shoulder. The speed test is specific for biceps tendon pathology and is done with the arm in forward flexion, but supinated with the palm up and then pushed down. Injection techniques into the glenohumeral joint. We usually use a large syringe, 10 cc's, but smaller, 5 cc's may be used. And we put 2 cc's of cortisone and diluted the rest with local anesthetic. The technique is to start about 2 centimeters medial to the posterior corner of the acromion and about 1 centimeter below it, and aim for the coracoid, in other words at right angles to the spine of the scapula. The needle can be seen to be inserted here in that direction and the injection given. But what happened here was that the needle was not long enough to reach the joint. In such a case, one may decide that one needs a larger or longer needle, specifically a spinal needle, to reach the joint. The spinal needle is inserted in the same place, in the same direction, and the injection is given, and free flow is felt, which usually indicates intra-articular placement. And in this case, you can see how drops are coming out of the needle, proving that there is intra-articular placement. To do glenohumeral joint injections with ultrasound control is very accurate. And the first one here is shown with the needle not in the joint because the fluid is leaking outside the joint. And this shows you the humeral head, the fluid outside, and the glenoid on the right side. But this was unsuccessful. When the needle is accurately inside the joint, and as one injects, you will find the fluid exiting the needle in the joint with no leakage. And again here you see the tip of the needle between the humeral head and the glenoid. Level 2 is the subacromial space, which is the space between the rotator cuff and the acromion on top. The bursa is also in this space, and remember that 50% of the bursa is anterior to the acromion and not underneath the acromion. Pathologies occurring in this space is impingement of the rotator cuff against the acromion, rotator cuff tears, as well as calcific tendinitis. In this picture, one sees the frayed out acromion on top and the frayed out rotator cuff beneath. This is a rotator cuff tear with a wide gap seen with a humeral head visible through the hole. And this is calcific tendinitis, where the calcium is seen in the subacromial space. The Hawkins test is for impingement of the rotator cuff underneath the acromion. The arm is lifted up and the humeral head squeezed below the acromion to squeeze the rotator cuff between the head and acromion, proving impingement. The Job test is mostly for rotator cuff tears, and the patient elevates the arm with the thumb down, and a positive test would give pain and weakness, indicating the presence of a rotator cuff tear. With a Joachim test, the arm is internally rotated and abducted, and the patient resists a downward pressure by the examiner, and this would usually lead to pain and weakness in a rotator cuff tear. Resisted external rotation is done with the arm by the side, and the patient externally rotates the arm against resistance by the examiner, and this would usually be weak in a tear of the infraspinatus. To inject the subacromial space, the technique will be shown here. We use a 5 cc syringe, usually with a 21 gauge needle, and 2 cc's of cortisone diluted to about 5 cc's with local anesthetic. The entry point is anterior third of the acromion, but try and go beneath and then upwards against the acromion to try and enter the subacromial space. Usually there would be a free flow of fluid without resistance. This injection can also be given with ultrasound control, and in this demonstration you can see the needle coming from the left upper hand corner into the bursa and the fluid entering the bursa just above the cuff. The needle seen here, the bursa, and the injection accurately placed. The next level is the AC joint on top of the shoulder, the upper level or the attic. This little joint between the clavicle and the acromion has ligaments which stabilize it, as well as a meniscus which is present in 10% of cases inside the joint. Pathology in this joint is arthritis, as well as osteolysis of the distal clavicle. Looking into the joint here with an arthroscope, one can see the severe degeneration of this joint, and you also see the punched out lesions on the distal clavicle, which also referred to as osteolysis, as seen in this slide. The test is localized pain, cross-body adduction, resisted extension, hyperabduction, and internal rotation in the abducted position. Localized pain on palpation is very typical of this condition and it should be regarded as a very sensitive clinical sign. You can see you push here in the soft spot just behind the joint, and just in front of that is the localization of the AC joint. Resisted crossover test is very accurate, also called the O'Brien's test for AC joint, and usually elicits pain if the AC joint is implicated in the clinical picture. The technique to inject the AC joint: as much smaller volume can be used, a 3 or 5 cc syringe, and the volume is 1 or 2 cc's of cortisone diluted to 3 cc's with local anesthetic. The joint is found at the end of the clavicle, and one may walk the needle until you find the loss of resistance where the needle enters the joint, and the injection is given at that point. This injection can also be given under ultrasound control, which makes it a bit easier, but is not entirely necessary. And in this picture one can see the needle between the clavicle and acromion and the fluid entering the AC joint. The joint capsule is shown and the joint space with the needle. Here we see again the 3 levels in the shoulder joint, which can each be particularly injected with therapeutic and diagnostic benefit. Other injections can be given and may be a bit more specialized, like into the biceps groove and the suprascapular nerve. The biceps groove has to be injected with ultrasound because any other method will be bound to failure, and this would confirm bicipital tendonitis and also be treating such tendonitis. Here one can see the needle going into the bicipital sheath just around the biceps tendon, and one can see the tip of the needle there, biceps tendon inside the sheath. Suprascapular nerve injections are given for pain relief in frozen shoulders and also cuff arthropathy and irreparable cuff tears. The ultrasound is used to locate the suprascapular notch, and the nerve stimulator would confirm the location. In this picture one sees the ultrasound picture of the needle as well as the needle in the space. We thank you for your attention, and this was an indication of how to give these injections accurately with hopefully great beneficial effect both on diagnosis and therapy.